Heart failure is a chronic and progressive condition affecting millions of people worldwide. It arises due to the heart's inability to pump blood sufficiently to meet the body's needs. Early diagnosis and optimal management are crucial to improve patient outcomes and prognosis. However, delays and inadequacies in current diagnostic practices often lead to late or missed diagnoses. This negatively impacts treatment effectiveness and increases morbidity and mortality rates. This lecture aims to discuss guideline recommendations for the use of diagnostic tests in heart failure according to current evidence. It will describe real-world diagnostic practices and their shortcomings. An optimized approach will then be proposed to ensure timely diagnosis and management aligned with guidelines. The discussion is supported by relevant literature and real patient case examples. The European Society of Cardiology, ESC, guidelines provide a framework for the appropriate use of diagnostic tests in suspected and known heart failure. Clinical assessment. A thorough clinical history and physical examination should always be the initial steps. Key signs and symptoms include breathlessness, ankle swelling, fatigue, and elevated jugular venous pressure. Chest X-ray is recommended as the first-line imaging modality to exclude other cardiopulmonary pathologies and assess heart size, pulmonary congestion. Echocardiography is the recommended primary diagnostic test in suspected or known heart failure to assess ventricular function, valve disease, and morphological anatomical abnormalities. It is non-invasive and provides structural and functional cardiac information. NT-proBNP testing. Plasma BNP NT-proBNP levels aid in ruling in or out the diagnosis when uncertainty exists after initial clinical evaluation and chest X-ray findings. Elevated levels support a diagnosis of heart failure. Electrocardiogram, ECG, provides information on rhythm, conduction abnormalities, prior myocardial infarction or hypertrophy. However, ECG findings alone are not diagnostic of heart failure. Cardiac biomarkers, troponin and CKMB measurements help diagnose underlying acute coronary syndromes or myocarditis in acute heart failure. Diagnostic clarity is needed before initiating evidence-based pharmacological and device therapy according to guidelines. Multidisciplinary care involving cardiologists, specialists, and general practitioners optimizes patient outcomes. Real-world diagnostic practices often do not fully adhere to guideline protocols. Studies show delays, underutilization of recommended tests, and diagnostic uncertainty negatively impact patients. Delayed diagnosis is common. A US study found the median time from symptom onset to initial heart failure diagnosis was over 1 year. Failing to order recommended initial tests like chest X-ray and BNP testing by family doctors leads to late recognition. Often, comorbidities mask symptoms, leading generalists to misattribute them or not consider heart failure. Failure to utilize recommended tests like echocardiography at early symptomatic presentations prolongs the time to accurate diagnosis. Studies have identified multiple factors contributing to current suboptimal diagnostic practices. Lack of adherence to guidelines by non-cardiology specialists, who manage the initial presentation in most cases. Failure to appreciate heart failure as a plausible cause in the presence of comorbidities like diabetes, hypertension, or obesity. Over-reliance on clinical examination alone without ordering recommended basic screening tests. Delayed specialist referral until symptoms are very prominent and advanced disease is revealed on tests. These weaknesses in the diagnostic pathway undoubtedly impact long-term treatment and prognosis for heart failure patients. Later diagnosis correlates with worse outcomes, including higher mortality. An ideal approach should minimize diagnostic delays through prompt initiation of recommended screening tests and early specialist involvement as per guidelines. Some key elements of an optimized model are continuous medical education, CME programs, updating non-cardiology healthcare providers regarding heart failure diagnostic protocols will promote adherence to recommended first-line tests like chest X-ray and BNP analysis. Easy access to basic screening tests, streamlining processes to make chest X-ray, ECG, and BNP testing easily available even at primary care level through public-private partnerships reduces delays due to logistical barriers. Early specialist referral pathways. Establishing clear referral criteria like abnormal screening test results or persistent worsening symptoms despite initial therapy will facilitate timely specialist assessment and definitive testing. Multidisciplinary disease management programs, coordinated care involving cardiologists, primary doctors, nurses, pharmacists, dietitians, ensures adherence to guideline-directed medical, device, and lifestyle therapy. Community education, increasing awareness in at-risk, vulnerable groups regarding typical symptoms, will encourage early health-seeking behavior and swift initial evaluation by family doctors. Point-of-care testing. Technologies like handheld echocardiography and portable BNP analyzers at family medicine centers allow instant diagnostic information, guiding immediate referral decisions. Electronic health records. Centrally accessible records flag abnormal prior tests to avoid test repetition and prompt repeat advanced testing if initial treatment response is inadequate. Performance quality indicators. Tracking metrics like time to first cardiac tests post-symptom onset, specialist visit intervals, or adherence to testing protocols incentivizes improving the diagnostic process. The above multifaceted strategy optimizes each step in the diagnostic pathway to minimize delays through standardized protocols, coordinated care models, and ease of access to recommended guideline tests. Early accurate diagnosis thereby paves way for timely, optimized medical and device therapy, improving clinical outcomes. Poor alignment with diagnostic guidelines, diagnostic uncertainty, and delays in specialized testing adversely impact heart failure outcomes. While clinical history and examination form the initial evaluation, objective tests are needed for confirmation, as symptoms can mimic other conditions. Implementing an organized diagnosis-focused program, incorporating elements discussed above, is vital to translate guideline protocols into real-world practice. It recognizes the shortage of specialists by equipping generalists, exploits technologies to decentralize testing while coordinating multidisciplinary care delivery. Quality improvement indicators must track key performance metrics to identify gaps and drive process improvement. Policy support through healthcare resource allocation is required to implement necessary infrastructure and capacity-building measures. Overcoming diagnostic barriers will aid early institution of evidence-based heart failure medications, devices, and lifestyle interventions. This promises substantial benefits, including preventing disease progression, recurrent hospitalizations, and reducing high mortality rates associated with advanced disease detected too late. In conclusion, an optimized diagnostic model, adhering to current guideline recommendations through systematic protocols focused on minimizing delays, holds the key to timely and accurate diagnosis of heart failure. This ultimately improves patient outcomes by facilitating prompt institution of optimum care and management aligned with best practices. A team-based coordinated care approach is vital in ensuring seamless translation from screening to specialist-guided long-term follow-up and support.
Two real patient case studies help illustrate the impact of timely diagnosis and management aligned with guidelines. Mr. C, a 68-year-old man with a history of hypertension and obesity, presented to his primary care doctor with swelling of feet and exertional dyspnea for 3 weeks. Chest X-ray and BNP test were done as per the optimized diagnostic approach, which revealed mild pulmonary congestion and elevated BNP levels, 700 p.g/ml. He was promptly referred to a cardiologist. Echocardiogram confirmed reduced EF of 35% with mild mitral regurgitation. Treatment with ACE inhibitor, beta blocker, and diuretics as per guidelines was started. At 3-month follow-up, his symptoms resolved with reduction in BNP to 100 p.g/ml and improvement in EF to 45%. Strict adherence to medications and lifestyle modifications were emphasized. Proactive initiation of appropriate screening tests promptly recognized his condition. Early involvement of a cardiologist enabled timely institution of evidence-based medication as per guidelines. Close monitoring resulted in symptom relief and stabilized cardiac function, thus preventing progression to advanced disease. Mrs. D, a 75-year-old diabetic woman, had worsening swelling in both legs for 6 months, initially managed non-specifically by her family doctor. When her symptoms escalated with cough and orthopnea, specialist consultation was sought and echocardiogram was done. It revealed severely reduced EF of 20% with severe global hypokinesis. Medical optimization initially failed due to advanced disease. She was rapidly deteriorated, requiring inotropic support and mechanical ventilation. Ultimately died due to refractory cardiogenic shock before consideration for advanced therapies. Delayed seeking of expertise and initiation of tests directly resulted in advanced disease manifestation, poorer prognosis, and mortality despite treatment. Absence of an organized diagnostic protocol with reliance on subjective clinical assessment alone contributed to lack of timely diagnosis and management. These case vignettes highlight that an optimized pathway guided strictly by guideline recommendations minimizes diagnostic delays. This provides opportunities for early specialist intervention and ensures institution of care in line with evidence even before disease progresses. Ultimately, clinical outcomes are improved compared to current unstructured practices. While several barriers currently impede timely diagnosis, overcoming them requires multi-pronged efforts and resources. Most diagnostic tests are not uniformly available at community levels due to logistical hurdles like infrastructure, trained manpower, and funding constraints. This is a major impediment in developing nations. Investing in public-private partnerships to decentralize basic cardiac testing using portable technologies can bridge such gaps. Graded implementation based on local needs and resource availability is important. Changing clinical practices ingrained over years also involves challenges. Passive dissemination of guidelines alone is inadequate. Incentivizing quality metrics, audits, feedback mechanisms, and certification programs aid uptake of standardized protocols in real-world settings. Significant healthcare provider retraining needs to familiarize non-cardiologists with diagnostic algorithms. Continuing education linked to accreditation maintains skills and adherence. Teleconsultation supplements limited specialist access in rural areas. Cost implications of additional testing require judicious resource allocation and prioritization. For example, selectively using NT-proBNP to avoid echocardiography in stable low-risk patients lowers expense. Technology like big data, AI assistants, and mHealth apps also promise to revolutionize diagnoses. However, data security concerns and limited validation hinder widespread clinical integration currently. Addressing socioeconomic barriers preventing access to care is equally crucial to avoid disparities. Subsidies or public health insurance can decrease financial barriers to timely healthcare seeking, more so during pandemics as occurred with COVID-19. While obstacles exist, a multi-pronged strategy tailored to local requirements through collaborative stakeholder actions can potentially overcome them. The significant clinical and economic benefits of optimized diagnosis motivates investment into overcoming existing barriers. Heart failure poses huge healthcare burdens with its progressive nature and impact on quality of life. Simple, non-invasive cardiac tests recommended by guidelines effectively support or refute the diagnosis when doubts exist clinically. However, their benefits are not fully realized in current practices, marred by unjustified delays. Adopting a structured diagnostic approach, prioritizing prompt initiation of screening tests, and coordinated multidisciplinary care delivery is pivotal. It ensures early specialist evaluation through coordinated clinical pathways and electronic reminders. Access to basic testing, even at primary care levels, coupled with continuing education programs, promotes adherence to standard protocols. Implementing validated models demands collaborative efforts and resources from various stakeholders. Overcoming socioeconomic barriers further aids equity in diagnosis. Continual quality improvement through metric assessments and research establishes best practices as technologies advance diagnosis. When optimized diagnostically through adoption of standardized processes emphasizing timeliness, patients certainly benefit from evidence-based management aligned to guidelines. This translates to stabilized cardiac function, improved clinical outcomes, and healthcare cost savings. Most importantly, it offers heart failure patients an improved quality and duration of life by facilitating early diagnosis.